Why nerves matter in bipolar care? Can better bipolar care start with nerves, either at the front line or even during the whole process? Welcome to Bipolar Talk, the podcast when we turn our bipolarity into an opportunity. I'm Clément Baissat, the founder of HopeStage and also Bipolar Type 2. And today we explore the pivotal role of psychiatric mental health nurses in access. So how do you actually get to day-to-day stability, and how you can gather a team around you with different professionals? My guest is Torri Spencer, MSN PMHNP-BC, owner of a Sound Mind Behavior Health, providing holistic, culturally competent care across teen and adult. And can you just present yourself, actually, Torri?
Yes, for sure. You did really good. It's a lot of letters. My name is Torri Taylor Spencer. I just go by Torri. I am a psychiatric nurse practitioner. All the letters they stand for psychiatric mental health nurse practitioner. And then the BC is because I am board sort of certified. For me, I'm like in between a nurse and a doctor here in the United States. Um, I am still a nurse technically, but I don't work at the bedside. We're considered mid-level providers or practitioners. So most nurse practitioners are mastered, prepared at minimum. Some of us have doctorates. I do not. I just have my master's degree. And I am nationally certified to treat psychiatry across the lifespan.
Yeah, maybe we can go a little bit deeper into this process because I feel for us as patients, there's so many names and we kind of a bit lost. Okay, so can you tell us a little bit like what is the role of a nurse and what is the role of a nurse who has like a master in psychiatry? So what is the main difference? And as a patient, where should I go and when?
Okay. So the two major differences are going to be the education and the schooling. While you have several bedside nurses who are RNs or licensed practical nurses, they are typically working in clinics and hospitals and nursing homes. Um, Providing that bedside assistance, right? Maybe putting in your IVs. They're the ones that you're seeing all the time. And then they're usually that middleman between the patient and the doctor, especially in the hospital setting. And those nurses, RNs, registered nurses, they they can have master's degrees and not be nurse practitioners. So the schooling gets kind of nuanced. So with nurse practitioners, we have additional education, right? Our minimum degree is a master's degree. Okay. It is a master's degree. So with that, there's different responsibilities. And then again, we work in different settings. When you are a nurse practitioner specifically, usually you specialize in something specific, right? So for me, I'm a psychiatric nurse practitioner. When I went to grad school, my focus was primarily on psychiatry. When I did my national certification, I tested under psychiatry. Okay. And then for like there are other specialties. There are neonatal nurse practitioners who work with premature babies. There are family nurse practitioners who kind of act as general practice providers. And there are women's health nurse practitioners. There are nurse practitioners that work in dermatology. It it really can go the full gambit. We're again that kind of intermediary between a doctor and a nurse, whereas we're not at the bedside per se as much as we were when we were working at the bedside, but we also still need that collaborative um just coverage from a medical director or a MD or doctor. So nurse practitioners, we can still diagnose whatever our specialty is in. Like for me, for example, I can still diagnose, treat, order tests, lab work, um, make referrals, complete disability paperwork. I can still do all of that. In my specific states that I practice in, I practice in California and Missouri. And so in California and Missouri, they're both considered restricted practice states, meaning nurse practitioners have to have a collaborative MD in their specialty. So, for example, I have a collaborative MD in California that I work with, and one in Missouri that I work with, and they are both psychiatrists. Um, and so w- I basically have them for support. So, nurse practitioners, to sum it up, really fill a unique gap in that access to care for a lot of people who can't get in to see a psychiatrist for 6 months, or for someone living in a rural area where the closest doctor is several miles away and maybe they don't have access to get there as much as they can. They could see a nurse practitioner, who has more availability. So, um, I think we're in a really, significant spot where we're at right now. And I think nurse practitioners as a whole across the United States are all working to gain that full practice to really work at the top of our license, because while there should be parameters there, there are a lot of us who have that experience, who have worked alongside doctors for years, who have had that collaboration for years, and we should be able to work at the top of our license in every state. And so, right now there are some states that allow nurse practitioners to function independently without that collaboration. So something they're working on in California, I know, and we're fighting for it in Missouri too.
Yeah, I feel like it's different in every country. So I'm originally from Paris in France, and there is this kind of thing, but I feel it's a bit less common,
Mhm.
and it's really needed because what we're seeing is like this decline of number of psychiatrists, and yeah, we need more and more help in mental health, and and I think I really like also the fact that you work as a team, which is like much more needed. That I
Yeah.
think what is done, you really have like in hospital care when you have the full team, and then you get out of the hospital and you're like, and you're lucky if you can have like,
One person.
yeah, one person will see you every 3 months. If we say
Mhm.
it's a psychiatrist, most of the case, at least from what I see.
For 15 minutes, if that.
Yeah, exactly. And it's like if you have like a small team, like just for the moment, just nurses, psychiatrists, already like much better than most people. And yet you talk a little bit about like you're working with two different psychiatrists. So how does it work? How's your relationship is? And do you refer each other? Like, yeah, I'm curious about it.
Yeah. So, I'll talk primarily about my collaborating psychiatrist in California. She's been my collaborator since I graduated, so for about 3 years now. Um, and she's been there through a lot of ups and downs in my career in general, and the transition from going from bedside nurse to mid-level provider, or practitioner where everything is on me. And that is a whole nother topic, that transition is hard sometimes. Um, and so she's been there with me every step of the way and throughout me building my private practice. So she's really been there through a lot. She's literally a phone call away. She's literally a text message away, like no matter what time of the day, she is always available. Um, and she's not even local and could be local if I needed her. So, she's got a lot of experience. She was Kaiser is a big hospital system in California, and she was like a regional director or something for Kaiser at one point, which is a huge accolade. She's got her own businesses. Her primary specialty or subspecialty under psychiatry is addiction medicine. Um, and I just love the way she supports nurse practitioners. She fully stands behind us and she supports us. She's such an educator. Like, she started like a Substack. She started so many like things for me and a few of the other nurse practitioner that she collaborates with. And how it works usually is um if I need her, she's there. As advanced practice nurses, we go through school and we're kind of put out there and expected to here do the job. Like, you have the nursing experience, you have that advanced training, you pass the boards, you know what you need to do, so there should really be minimal hand holding. And that's kind of how it is. And for Dr. Groward, who is my collaborator in California, Lauren, she's amazing. I feel like she teaches in a way that it's not hand holding. She's going to make me critically think, and I need to already come to her with what the plan is, and we can kind of talk through that. And I think those some of those moments when I did, need that advice or that collaboration, or even that reassurance, especially first starting out, it helps
So
so much in
from
the learning.
I want to go back a little bit from a patient perspective, because I understand like it's great, like you have a great relationship, but how does it work as a patient? So you go and see, like, for example, your partner in California, which is a psychiatrist, and then how does it work? Like, if she referred to you and then you work as a team, how many meetings, like how does it go?
So typically the work, especially for me because I have a private practice, right? So the private practice is my practice. I am the sole provider. There are no other providers, including Lauren, who are seeing patients besides me. She does not refer any patients to me. I get all my patients organically, whether that be through my own marketing or just word of mouth from relationships that I've built with like therapists or other providers. So that's typically how I don't refer any patients to her. She is there if I need her for a patient case. Like, let's say you're a new patient of mine and you're a really difficult, quote unquote, case for me. And I'm like, I'm not sure what to do. And for me, I'll have that conversation with my patients like, okay, we've been through 20 medications. Let me collaborate with Lauren on this and get her advice on this case. And I'll go to her, hey, this is the patient that I have. This is the history. This is what I'm thinking. Any advice? And that's how our collaboration works. Now, if for whatever reason I ever had a patient that was like, I want to speak to your collaborator, they could. I've never had that happen. Now, if they wanted to see a MD instead of an NP, they can do that too, but usually I don't have that problem. Most of the time, my patients are coming to me knowing that I am a nurse practitioner. So they're not confused in any way that I am a psychiatrist. Although after establishing care, they will still call me their psychiatrist. So it's confusing for patients, and I totally understand that. I just try to, like remind them. I always say, like, no, they'll be like, all right, doctor. And I'm like, Tori, Tori, not doctor, not a doctor at all.
No, but it's normal because I put myself in these shoes as patient when I was diagnosed in 2019, 20 actually, and you're just lost. You're like, who should I see? How do I know it's the right fit for me? And you have like people like showing your name, and you don't know, like, should I go see a psychiatrist? Should I go see a nurse practitioner? Should I see a psychologist? Do I need a bit of each? And you're just lost. So
Yeah.
if you put yourself in my shoes, you've been diagnosed by a psychiatrist for me, and and then the person who diagnosed me, to be honest, I didn't want to continue my care because I, she was, I can tell, like overwhelmed. Like she had like a
Mm,
lot of patients, like 10 minutes. After 10 minutes, she told me like, okay, you take this pill. And I was like, I needed to have like a deeper conversation, I would say, because I was still a bit shocked, and she wasn't even taking patients, so I was a bit lost. So, what's your advice, Tori? Like, how do you know who to see, and what questions should we ask ourselves as patient to
yeah.
find the right practitioner?
Yeah. So starting out, if you know that, okay, I need to see somebody for my mental health and the goal is I'm most likely going to need medication management, you're going to need a prescriber, right? So that's either going to be a psychiatric physician's assistant, that's going to be a psychiatric nurse practitioner like myself, a psychiatrist, a doctor specializing in psychiatry, um, and in the I don't know if we have them here at all in the states that I practice in. I think maybe somewhere in the United States, there are very rare cases where I think psychologists can prescribe, but I don't know any that do. So for the most part, it's either going to be some type of mid-level provider like a nurse practitioner or a physician assistant or a psychiatrist that you're going to need to see. Typically, across the board in the United States, it's taking months to get in to see a psychiatrist. So if I am a patient actively going through something, if I'm nearing the end of that 30-day supply that the inpatient unit started me on and I'm getting ready to run out and I don't know what to do, or I've switched providers or my, provider isn't refilling my meds or whatever the case is, um, if I am needing that assistance and say my preference is to see a MD over an NP because some people do feel like that, um, then schedule for an MD, but also be open to seeing a nurse practitioner. And if you are open to seeing a nurse practitioner just kind of from the jump, schedule with them. And I think across the board, I always tell my patients and they laugh, they're like, you're so crazy, sorry, but you're right. I always say it's kind of like dating, like finding a provider. You got to find somebody who you're going to feel comfortable enough being open and vulnerable about probably some of the most, scariest things and toughest times that you've experienced in your life. And you also want to be heard. You also want, there are so many aspects there. And you're not just going to get that off the first provider you meet, regardless if it's a regular doctor, a foot doctor, a dentist, whatever. But, specifically for psychiatry, I think that it's important to I have some patients that come to me and they're like, I've been through like 5 different doctors or nurse practitioners and I just can't find the right one, and they're embarrassed about it, and I'm like, Why do you care? Why do you care? Like, so what? And you haven't found the right one. So keep jumping until you do. Like, you wouldn't settle for less than a marriage, right? So you shouldn't do it with the person that's prescribing your psychotropic medication, you think? So I would say if you're open to seeing a nurse practitioner, even if you're not ha take get that one appointment. You're likely going to be seen sooner, and you're likely going to be seen for a longer amount of time. And if you don't like it, then you don't have to schedule. You don't have to schedule again, or you could try somebody else. So, I always think it's worth exploring, especially if your mental health is on the line.
Quick break. Can you let us a review on Apple Podcasts or the platform of your choice? It really helps us break the stigma around bipolarity. Let's get back to the episode.
I fully agree. And I think it's a great advice. It's like, I know it's difficult because we see our practitioner as sometimes like stronger than what they are a little bit. You are like you're patient. So I am a patient, and sometimes you go at the beginning. I went to see my psychiatrist, and I was like, whatever he says is like the truth on earth, and I couldn't like ask for anything or say really what I felt. And it took me some time to accept that no, I'm the customer in a way, and I need to share my feeling. And it's difficult because you don't want to say things and to be like, oh, but I think my dosage is not right, or I don't want to take this pill yet. I want to wait, or and having those hard conversations. Like, I never stop my med, but if one day I wanted to do it, then it's having the conversation also, and it's difficult. But that's the best way, because if you want Torri, for example, to help you, she needs to understand what's in your mind, and she will guess some stuff, I'm pretty sure. But it's like, so, and also something that you say, it's like dating. I fully agree. Is like, how do you build trust with this person? Do you want to see this person? Do you like seeing this person? It shouldn't be like a burden to you to go and see your nurse practitioner or your psychiatrist. It should be a nice moment where, of course, you're going through deep stuff and it could be difficult, but at the end, you feel great about it. So I think it's really one of the thing. And so to go back a little bit, like, what do you do in a session? So how long does it take? What do you work on? Do you do psychotherapy? Like, how does it work?
Yeah. So for me, all new patients, typically this is kind of the new patient process. Somebody will either be referred to me or they will find me somewhere, online, and they reach out to me, either call, email, text. There's a lot of ways to get a hold of me. And so somebody will reach out, and either myself or my assistant Lainey will offer a um consultation call. And so I offer a 15-minute, no charge, no obligation consultation call. And that is literally to see if you think it's going to be a good fit, right? Quick 15-minute call. I usually have people tell me, hey, this is what's going on, and I'll say, okay, what are your goals for treatment? What are you looking for? How are you kind of feeling about things right now? How quick are you needing to be seen? They run all that down to me. And then I kind of tell them what services I provide. I tell them a little bit about me and my practice. It's very informal, and how I am right now is how I am with my patients. And so I think just my personality makes it a little bit easier. Like even on the phone, people are almost like, oh, I feel so much better, even after this little 15-minute call, and I'm like, okay, and it's up to them, I'll give them, any additional information they need about, myself or my practices or services I provide. Um, and it's usually up to them to reach back out if they want to move forward with scheduling an appointment. Usually, most of my consultation calls turn into appointments, and people are usually ready to schedule. There are some insurance plans that I do accept, and I do accept private pay or cash pay in patients. So, depending on if they are, using insurance for coverage, that may take a little bit longer for me to see them, but usually I can see people within about 3 weeks or so on average, maybe a little bit quicker for the cash pay and patients because we don't have to wait on insurance verification and stuff. Um, so all new patients are then scheduled for a initial exam, and so for me, it's called a comprehensive initial psychiatric exam or evaluation, and those are all scheduled for 90 minutes. Um, and again, very informal. My patients do have new patient paperwork to fill out, and in that includes an intake. And it's a pretty lengthy intake. So I always thank my patients for like, thanks for going through that paperwork. That helped a lot. And I try, especially during that consultation call, to emphasize, please get this done because I don't want to waste your 90-minute appointment on administrative tasks. And it's also going to help me get a better assessment and more holistic picture if I have some information beforehand. If there is a provider that I can speak with or somebody I need to speak with who was handling your care before, or for example, your therapist, if you're in therapy, it would be great if I can get that collaboration going before we even meet. And so most patients will at least get the intake form done. Maybe not everything else, but they'll get the intake form done. Again, that allows me to kind of review in detail a little bit more. And then we have that first visit. Again, it's 90 minutes, very informal. It's me just asking them a bunch of questions. And for my patients, I think it doesn't even feel like interviewish, like me asking them questions. It's more of like we're having a conversation, right? And I'll have a lot of people end up stopping mid sentence and being like, I don't even know if that matters or if you want to know that. And I'm like, no, keep going because little do you know, it's giving me a better picture of, things. You start going on and on about this stuff that happened when you were 9, 10, 11, 12, and you're thinking it's totally pointless. And for me, I'm putting all these things together. So that's why I do such a long initial appointment because I know most psychiatrists and other nurse practitioners will usually do about an hour for a first visit. I talk a lot. If that means I'm getting more information, that's fine with me for my patient because it's going to help me better treat. After that, it kind of depends on what the plan is. I also like to extend that first visit to 90 minutes so that we do have time to discuss treatment planning. So if I've, developed my assessment near the end of that 90 minutes, like maybe at that 60, 70-minute mark, we're usually saving that for treatment planning discussion. Sometimes, especially for extensive cases, we've got to schedule another appointment. Um, but most of the time we can get the treatment planning discussed in that initial appointment. It doesn't always mean we do something at that appointment, but at least we talked it out. And for me, that's giving all the options available to my knowledge or at that time that I think would be helpful and why. And we talked that out. You know, they again, I advocate for my patients to be real and keep it honest. If you're like wondering about something, or if you're like, oh, I heard bad things about this medication, or if I have a patient that's like kind of hesitant, I'll ask follow-up questions. What's the hesitancy? Let me know. Let's talk about it. And sometimes it works, sometimes it doesn't. I meet my patients where they're at because, again, I tell them, you're the professional on yourself. I can't tell you what's going on in your brain and your body. Am the professional with the medications. And for any, I feel, psychiatric prescriber to not be like there's some trial and error there with what we do specifically, it's BS because it is. Like the statistics show that there's only like a 33% chance of the first antidepressant you give working. And then it goes down after that. So it's like, I'm going to listen to my patient. If they're telling me they've been on something before and they've tried this, that, and the third, and they've had horrible side effects, I'm not going to be like, "Ugh, let's go back on it. I don't care what you're talking about." Like, no. And then I'm also going to give people options. Not everybody is ready to start a prescription medication. Some people want to do something more natural and more holistic. I am there. I promote it. I built my practice off my own values and beliefs. So that's why I practice more integrative psychiatry. Like, we are going to look at everything. Let's look at some genetic testing if we need to. Let's look at a full panel of lab work. Do I need to refer you out to another specialty? Let's do that and then follow up. So that's typically how the appointments go. I know I kind of ran off a little bit. Depending on what we're doing. So if we are prescribing medication or starting a new holistic regimen, we're usually following up every at least 2 to 4 weeks. Most of my patients stable or pretty stable. Once they get stable, we're meeting about once every month. And I do some psychotherapy. I am clear that I am not a therapist at all. I am not a therapist at all. In my graduate program, we were trained very briefly on psychotherapy and had to do some clinical rotations with therapists. So we got that experience there. And I also do as much continuing education on psychotherapy as I can. And so while I don't specialize in any specific therapeutic modalities, I do believe in some forms of CBT, the cognitive restructuring. I talk about that with my patients so much. Um, I am big on kind of solution focused mindfulness, like grounding work, breath work. So I'll do a lot of most of what I do, honestly, is talk therapy with a little life coaching thrown in there, and a little people feel like they're talking to their friend and getting good unbiased professional advice though. So most of my patients, my follow-up patients after that initial appointment, they're usually scheduled for either 30-minute visits or 60-minute visits. The people who want a little bit more talk therapy will schedule the 60-minute appointments, or if there's a lot going on for medication management, the medication management piece, sometimes we got to talk about that for 30 minutes or so and then do 30 minutes of talk therapy. So for me, yes, I do provide psychotherapy in all my sessions. I think it's important, and that's not, I tell my patients, what we do isn't a replacement for your therapist. It's in addition. They are trained in this, and so you should be going to psychotherapy along with your medication management. That's going to give you the best outcome. But talking to me for an hour a month is not enough. So,
That's one thing, like, which is a good sign if the person you're seeing is proposing you that when it's going better to see them less. As a patient is a good sign. It's really
mhm,
something you have to
mhm,
remember if you're listening,
mhm,
because it means that, yeah, the person just don't want to see you for money, just want to see you to make you better. And of course, it's going to be a money exchange, but It's really something that I figure out with a lot of psychiatrists also. One thing which is I feel important is also cultural like fit. And that's something I think we don't talk enough, I believe. Like some people, for example, some male want to see some male, and the other way around, it could be about color also. So I wanted to have your opinion on that. Do you see something different? Because it's really about like having the trust and having the link between the nurse in your case and the patient.
Yeah. I think that I see it a lot as far as gender. And I see it a lot culturally, but more for people of color, right? So for my patients who are, non-persons of color, they're like, I don't care what color you are. I don't care what ethnic background you come from. I just prefer to see a woman, and males and females. I have a lot of male patients that would prefer to see a female provider. And so I have that, demographic of patients, like no matter what their specific ethnicity or color is, I have a lot of patients who just want to see a woman. And I'm not sure what the statistics are, but I know in every setting I've been in, most of the psychiatrists or psychiatric providers, prescribers specifically, have been men. And, we see more female nurse practitioners in like the family setting. And so that's something that I've just noticed on my own. Maybe it's where I live. I don't know. But I've worked, in California and Missouri, and I think I've seen it in both states so far there. So you've got people that will wait 2 months to see a female provider than see a male provider in a week. you know so I do have a lot of patients who prefer females, and then of course for my people of color, representation matters, and I believe that wholeheartedly. And again, it's just a cultural aspect. There are a lot of my I'm African American. There are a lot of my African American patients who have seen so many non-African American providers who may have misdiagnosed or mistreated them just based on a cultural misunderstanding. And so, because there are not a lot of female psychiatric prescribers, there definitely are not a lot of um, Black female psychiatric providers. And I think that statistic is like less than 10%. So, there's not a lot of us. And so if I could be, that representation for somebody, if I can make a patient feel more comfortable because of the cultural aspect, that's what I'm here for. I mean, it's a passion of mine because a lot of the minority communities, not just the Black communities or the African American communities, I have all types of patients that are people of color, and they're like, I've been to so many white providers and they just don't understand me, and it's no knock against any white providers at all. But, it's like the cultural aspect does matter. It does matter, especially when you're talking about conditions of the mind, right? That are invisible, quote unquote, it's hard.
Yeah, and I feel also like if you talk about bipolar and of course I'm not a woman, but say some change of mood, maybe it depend on your cycle. And a man probably won't understand as much as a woman, is as simple as that. And but yeah, I think it's an important thing because I feel like as a patient, we sometimes a little bit like rolling the dice to find the right practitioner, and it should really be a thought system. Like, what do you want? Like, okay, do you want a woman? Do you want someone with the same color as you? Do you want a man? Do you want to have someone with a longer session or shorter session? Do you care about him or her being a psychiatrist, or doesn't matter? Do you want to have a team? So do you want to have, let's, for example, a psychologist, a psychiatrist, nurses, so you have a team around you? That's all the question you have to ask yourself, and really try to do a little list. And even after the consultation, to take a bit of time to be like, okay, what did I remember of what we talk about? How did I felt? Is it like, did I had a good feeling? And something that I do, which I feel we should do more as patients, is really like take the time to write what you learn after the consultation, because we tend to get out of here like job is done, but we didn't even let our brain just memorize what's happening. So what I'm doing more and more, actually, for example, with my psychologist, is like I do record the session, and then I have a transcript, and then I can reread the transcript and see what I want to work on and what I want to improve. So I would advise you, if you want to try to ask, like some people do accept it, some people don't, but it could be really interesting, because it's really like, just to quickly say about how memory work is like, we have the short-term memory and we have the long-term memory, and you need repetition to help from the short-term memory into the long-term memory. And when you're like spending like 60 minutes with someone great like Torri, we of course we'll put the link in the description if people want to contact you, but it's like you want to memorize what's going on. Otherwise, it's like you didn't lose your time, but it's almost like, yeah, you didn't get from what you could have. So going back a little bit into your practice, like, so during a 30-minute session, what information do you need from the patient to help them as most as possible, and how you want them to prepare for the session?
Yeah. So for a 30-minute session, those are going to be you're going to be seen at least once to have a 30-minute session. In that session, we're picking right up where we left off from that first, the session prior to, whether that was the first visit or, a previous 30-minute session. We pick up right where we left off. And usually for my patients, that's about 4 weeks, So I usually start off with my patients with, how you been? What's been going on? How's the past month been for you? How has things been? Like, because I genuinely want to know how have things been overall. And in that, patients will say things and, well, this happened and this happened and this happened. And I'm listening to all of it. And then I'll go through, my psychiatric review of symptoms, the same questions I ask at every appointment. How's your mood? How do you feel depressed? Have you had any thoughts of wanting to hurt yourself, hurt anyone else? Have you felt paranoid? Have you felt kind of off? How's sleep been? How's your dreams been? How have you been eating? What have you been doing to move your body? I ask all these questions. And sometimes I'll get patients and they'll tell me about the past month, right? And then I go through the psychiatric review of symptoms and they're like, I'm good. I'm good. It's okay. It's stable. And then I'll say, well, you just told me that mom had a heart attack and she's in the hospital, and little Timmy, just got kicked out of school, and your older kid won't stop smoking pot. And how are you dealing with all of this? How are you managing? Like, are you getting up on time for work? Are you hitting snooze? And so I try to dig a little bit deeper, and we kind of go from there. We talk about the medications, of course. How do you feel about the medications? If we made any changes at the previous appointment, how do you feel about those changes? Have you noticed any changes in any areas? um a big thing that I talk about at every appointment in that psychiatric review of symptoms is sexual health too. What's going on? Have you noticed any sexual side effects? Has anything changed on that end? And a lot of times no one's asking that question. And so patients are like, huh, now that you mention it, I didn't even think about it, you know? So it's, again, very informal, but me just kind of talking to them, you know. But for me, it's also assessing what's going on and what changes there have been in that last 4 weeks. And if there have been changes, you know, I have patients will be like, I'm so depressed. I think we need to up my medications. And I'm like, but you've got all this stuff going on. Remember, mom's in the hospital. Your son won't stop smoking weed. Tim got kicked out of school. You've got a lot going on. These are situational things. Like life can life sometimes, right? And it can do it all at once sometimes, and that can be overwhelming. You're not going to get a medication adjustment because things are going, you know, there's a lot going on right now. Let's talk about how we can manage some of these like situational stressors. Um, and then, you know, down the line, if we need to increase visits because it's a lot going on, let's increase visits to every other week or every week for some patients sometimes. Let's increase these visits. Let me collaborate with your therapist so we're all on the same page. Let's come up with a safety plan if things are very, you know, very dire. And if at all, you know, we need to, we can also always refer up to a higher level of care. So
Yeah.
that's typically how the follow-up appointments go.
Yeah, I think it's really important, like, to be able to accept that sometimes we need more and sometimes less. And the most important is to keep your appointment even if everything is well. And that's tough because you're really like, oh, but everything's good and everything. But that's where it's where you can do some work you couldn't done before because you're more like chill. And it's also about keeping the relationship and being able to have access to someone if something go wrong. Like let's say I see you every month, for example. Everything is well. Maybe I see you and then I'll tell you maybe next time in 2 months. But it could be the other way around. It could be like, oh, something happened. I need to see you, as you say, every week. And really like really having this conversation with yourself about how much do I need. But usually, like, if you have bipolar like me, you should probably never stop. At least is what I believe. Um, so a last question would be like, if you have a magic wand, Tori, what would you change in mental health?
I think that I would change the side effects to the medication. If I had a magic wand, like just because I think side effects drive so much of the like non-compliance and the stigma, you know, and just everything behind psychiatric medications. And so because this is what I do, right? This is most of what I do. Most of my bipolar patients need to be on some type of long-term maintenance medication. When they stop, it is usually either due to a side effect or access to the medication. So, I mean, like on a broader level, this wouldn't necessarily be just mental health, like free healthcare, you know, free healthcare for sure, because our healthcare sucks here. But mental health specifically, you know, like I just wish we didn't have any side effects with the medications because I think that the stigma would go away, you know, like the compliance would improve because the medications work, you know, they work. It's just tough, and especially with the trial and error. I've got to go through 10 different medications to get to the one that I need. Sometimes by the time patients are on that third or fourth trial, they're tired of trying and they give up because weed is easier to smoke, you know, and help my symptoms for now, or some other drug, you know, or alcohol, you know. And so I think a lot of that could be avoided. with better, a better side effect profile for some of for these psychiatric medications for sure.
Thanks a lot, Torri, for your time.
Thank
Um,
you. Thank you for the opportunity.
so I want to try something if it's you're okay with it. It's like having those like quick question and you have to answer like yes or no and quite quickly.
Okay. Okay.
I think it could be fun.
Okay. 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 Okay.
Okay, let's do it. One
I'm ready.
second. I'm trying so I can look at the camera a bit better. Okay. Ever had a patient who taught you more than any textbook?
Yes.
Is bipolarity still misunderstood in hospital?
Yes.
Can nurses spot the sign before the psychiatrists do?
Yes.
Does trauma show up in most of your bipolar patients?
Yes.
Oh, it's a lot of yes.
Mm.
Have you ever been in a situation where you see stigma in other clinicians?
Yes.
Do you think every nurse should be training in bipolar care?
No.
Can a good routine beat a bad day?
Yes.
Have you seen like story where medicine didn't work and then it just worked?
Yes.
Are you still hopeful about the future of mental health in the US?
Yes.
That's cool. That's a lot of yes. I'm happy about it. It means it's,
I think there was only one no, right?
yeah. No, it's like it's really something that I'm trying. So
I like that. I like that. I like that.
To learn more about bipolarity, go to our website hopestage.com, HOPESTAGE.com. See you soon.